This presentation is entitled Preoperative Patient Education, an EBM-EBP presentation by Bethany Evie. Anxiety is something many people feel on a daily basis, and undergoing any stressful situation increases that anxiety greatly. A surgical procedure can be a stressful situation to many patients, and anxiety is present from the moment the word surgery or procedure is mentioned. Anxiety has been found to increase postoperative pain by increasing serum cortisol, adrenaline, and noradrenaline. It is also found to increase mortality rates by increased risk of chest pain, dysarrhythmias, ischemia, tachycardia, hypertension, lipid profile, coagulation, and the immune and autonomic body systems. The hospital stay has also been found to increase due to the increase in pain and potential postoperative complications. By increasing the amount of education patients receive, the patient becomes more prepared and is able to reduce the anxiety level prior to procedure. It is very common for patients to have short education sessions with physicians prior to the procedure and then very little follow-up education from other staff. Patients may have questions after the education, but be unsure who to ask if the physician has left, or they might be too intimidated to ask. Even when education is provided, it is often done in medical terminology, and many patients do not understand the language and just nod their head to say they understand. Anxiety levels may even rise when education is provided because it is too much education all at once or in a language they don't understand. I decided to present on the topic of education because it is something I do every day. On the hospital floor I work on, we have a high patient population of minor heart attacks that require percutaneous coronary intervention or open heart surgery for a valve repair or coronary artery bypass graft. We also see patients that require a catheterization ablation for dysarrhythmias such as atrial fibrillation and non-sustained ventricular tachycardia. Many of these patients are young, in their 40s and 50s, and have never gone through a surgery before and are unsure of what questions to ask or how they are to feel. I see many patients who answer the question, "Do you have any questions about what is happening tonight or tomorrow?" with "Yes, lots," or with a terrified look on their face. I see a big sigh of relief from the patients after walking through the procedure or providing information on the postoperative period or just listening to their concerns of what life will look like after the procedure. By giving a small part of my day to explain the procedures in the postoperative period with the patients, I am able to immediately reduce their level of anxiety. With seeing this occur through my own eyes, I thought it would be really interesting to explore studies and statistics that prove that education is both helpful emotionally and physically. Anxiety is not something that will ever go away, but there are ways to decrease that anxiety felt by patients, and one way to do that is by providing the education they desperately need. The purpose of this presentation is to review 5 articles pertaining to patient education in reducing preoperative anxiety in surgical patients. The research question for this presentation is, does preoperative education decrease the anxiety level of patients undergoing various surgical procedures? When breaking down the question into its individual PICO elements, the patient population represented in the question is patients undergoing various surgical procedures. The intervention being provided is preoperative education, and the comparison intervention is standard education already provided prior to surgery. Finally, the outcome is a decrease in the patient's anxiety level. The literature search was conducted through Pennsylvania College of Health Sciences library database, which searches multiple databases at once. The keywords utilized on the first round of searching were education, preoperative, and anxiety. This populated 11,255 results. This was too large of an amount of articles to review, so the filters were added. The peer review only, full text online, and publication date in the last 5 years filters were added. This narrowed the results to 2,712. 4 articles were located in these results. The keyword effectiveness was added and narrowed the results down to 1,060. 3 additional articles were located. Only one of those articles was used in the 5 primary sources. Relevant articles, they needed to meet a certain criteria to get a variety of situations. The articles needed to represent a different surgery than the previous articles in order to see if the results were similar between different types of surgeries, from simple to complex. The articles needed to have different teaching techniques like video, face-to-face, brochure, etc., in order to see if there were similarities or differences in the teaching techniques. They also needed to have similar measurement methods in order to best compare the results. And finally, the articles needed to have a similar amount of patients in their sample size. These articles had sample sizes between 100 and 450. The process of locating the articles was effective and relatively easy through the PA College of Health Sciences library database. There were a large selection of articles available, which provided evidence that the topic chosen was well researched. All articles are very similar in the purpose or the aim of the study. They all were striving to see if certain education provided preoperatively affected patients' anxiety levels. I am unable to pronounce correctly all of the names of the researchers, so I will only attempt the first name and say et al. Afterwards. Kalgani et al., Haddad et al., Carmen Azul et al. Used a convenient sampling for their method, and Kasanen et al. And Wang Kita-Korn et al. Used randomized control selection for their sample method. In locating articles, it was attempted to locate only randomized control trials, but in noticing the results to be very similar to articles with convenient sampling, articles outside of randomized controlled trials were used. The sample size varied from 100 to 450 patients, and again the results were very close from one study conducted with 100 patients to the other study conducted with 450 patients. The sample inclusion for our articles included patients 18 years and older and spoke and understood the language utilized for the education and questionnaires. The exclusion criteria included patients with mental disorders, currently taking medication for anxiety disorders, and future scheduled surgery after the surgery completed for the study was done. The inclusion and exclusion criteria helped to eliminate any extraneous variables that may have influenced the results. The setting for all of the articles was within a hospital. 3 study designs were represented in the articles. Carmen Azul et al. And Wang Kita-Korn et al. Used an experimental design. Haddad et al. Used a quasi-experimental design, and Kasanen et al. And Kolgani et al. Used a randomized controlled trial for their study design. The designs also contain an intervention and a control group, and the results did not show any influence from the use of a certain design. The data collection process was very similar, yet different in all of the articles. Wang Kita-Korn et al., Carmen Azul et al., Kalgani, and Kasani et al. Used the State Trait Anxiety Inventory, or STAI form, to measure the anxiety levels of their patients. Haddad used a very similar form called the State Anxiety Inventory, or SAI form. This form only removed the trait anxiety portion and focused only on the state anxiety portion. There was no noticeable effect to the results in the use of the STAI or the SAI form. It used a basic form to collect data on the patient's demographic and clinical characteristics. Kasanen et al. Collected additional data on each patient's knowledge relating to the surgery by using a test called the Knowledge Test Feedback Intervention. Wang Kita-Korn et al. Also collected additional data regarding the patient's education topic request and the amount of education they requested to be given. In all of the articles, the study or intervention group received specific education and the control group received standard care. Several researchers did use different professionals to provide the education to the intervention group. Korn et al. Had physicians provide the education. Haddad et al., Kolgani et al., and Kasmanen et al. Used nurses to provide the education, and Carmen Azul et al. Used unspecified staff to provide the education. The different professionals providing the education did not seem to influence the results at all. The STAI and SAI questionnaires were provided at various times of the patient's surgery process. The majority of the times the questionnaire was completed was at the time of admission, which was before education, before surgery, which was usually after education, and after surgery. Various forms of education were used as well by the researchers. Kolgani et al. Used a booklet to provide the education to the patients. Wang Kita-Korn et al. Used video-based education, and Kasanen used a questionnaire through the telephone to provide the patients the intervention education. Lastly, Wang Kita-Korn et al., Carmen Azul et al., and Kolgani et al. Used one-on-one education with time for questions and answers with the educator. The anxiety levels reduced regardless of the method the education was provided. All of the articles used a significance level of 0.05. After all of the studies were completed, the researcher concluded that interventional education provided preoperatively reduces the anxiety levels of patients more than the standard education. According to the STAI/SAI results, the anxiety level decreased a little in all of the control groups and the intervention groups, but the intervention group reduced more. The numbers listed below of the difference from the admission STAI/SAI questionnaire to the discharge STAI/SAI questionnaire. Each questionnaire contained 20 questions with ranges associated with numbers on how the anxiety level for the patients were at that moment. Score ranged from 20 to 80, with 80 being the most anxiety someone can have and 20 being the least anxiety. Questions in the control group in Carmen Azul et al., Colgani et al. Had less than 5-point reduction from admission questionnaire to discharge questionnaire. The control group in Wanke-Kakorn et al., Haddad et al., Kasanen et al. Studies had a point reduction between 5 to 10. In the intervention groups in Colgani et al. And Kasanen et al., the point reduction was less than 10. In Wanke-Kakorn et al. Study, the intervention group had a point reduction between 10 to 15. Lastly, the intervention group in Carmen Azul et al. And Haddad et al. Studies the point reduction was 15 to 30 points. In those numbers, you can see how much of a difference there was in the anxiety levels in patients in the intervention group versus the control group. For the data collected on the demographic and clinical characteristics, there was no statistical significant results. The literature synthesis worksheet from Dr. Gennard's IPC 401 course in Blackboard was utilized to synthesize the articles. The worksheet was very helpful in synthesizing the articles. The articles were able to be broken down into individual parts and then compared and contrasted against the other articles. No challenges were noted during the synthesis process. A practice recommendation with using the research in the 5 reviewed articles would be providing a standard form of education to every preoperative patient. Communication about the procedure and what to expect before and after the procedure should also be provided. Carmen Azul states that patient education should be planned in accordance with patient's needs and start with increased communication as the patient is hospitalized. Haddad et al. Says well-structured educational interventions should be an integral aspect of the routine daily care for patients. It has been proven through multiple articles that the use of education prior to any procedure significantly reduces the anxiety level of patients. Some potential complications with implementing this process and practice recommendation would be the potential for increase in time needed in order to provide the education to every patient. Another potential complication is the increase in cost of the additional courses needed in order to teach staff the new standard education. Staff is needed to train other staff, and time is needed in order to provide the education. Anxiety is a common feeling in patients undergoing surgical procedures. Education is a simple way that we as healthcare providers can reduce the anxiety patients feel. By taking a little extra time and by funding a few extra courses for staff, a reduction in patient anxiety can be seen. Thank you for watching this presentation, and I hope you are able to take something away from it.